I think we went through a revolution sort of gradually over the last 10 years of understanding really the molecular basis of MDS. It was a relatively mysterious disease without known uh, drivers really until the last 10 to 15 years, I guess, when almost all of the major genetic mutations that lead to MDS have been characterized, and it's become routine clinical practice to identify the mutations in every individual patient with MDS. And that's led to much improved risk stratification of patients with MDS, of classification of the disease into more homogeneous biological and clinical entities, rather than uh, a more general heterogeneous group of syndromes. And I think another huge area for both the pre-malignant state and for MDS now is to understand non-malignant consequences of these mutations. In many cases, the mutations that drive MDS may lead to inflammation that can cause morbidity and mortality that is distinct from the progression to leukemia. And patients may have an increased risk of dying of cardiovascular disease, of pulmonary disease, of other inflammatory diseases. And understanding that can lead to preventive therapies that prevent that non-malignant mortality and morbidity, as well as the malignant progression. We really understand the progression of initiating mutations leading to a pre-malignant state, progressing to MDS, and which of those mutations then lead to, or which mutations lead to progression from MDS to acute leukemia. So we understand that biology and genetics at a granularity that was not anywhere that is orders of magnitude better than it was not that many years ago. What we now need to do is identify the optimal points of intervention in that disease progression, when patients should be treated and how. We need to develop new therapies, and ultimately, if we can develop effective therapies that have low enough toxicity, we can move that therapy to an earlier and earlier stage of disease progression.
Great.